pick up any pill bottle from your bathroom shelf right now. Just one. Look at the label. Now ask yourself, honestly, do you actually know what that pill does inside your brain while you sleep? Every 66 seconds, another senior in this country receives a dementia diagnosis. And in my 15 years of practice, I have sat across from enough of those families to tell you something that rarely makes it into that devastating conversation. For a significant number of them, the memory loss was not inevitable. It was not simply aging. It was a medication, one that a doctor prescribed, a pharmacy filled, and that everyone assumed was safe because of exactly those two facts. Here is what almost no one explains to you. In a 1-2 minute office visit, there is an entire class of ordinary, everyday drugs that can pull your memory and your learning capacity down hard inside a single year. And most of the people taking them have absolutely no idea it is happening. They notice the fog. They notice the name slipping away, the appointments forgotten, the drive home that suddenly feels unfamiliar. And everyone around them nods and says the same thing: you are getting older. That explanation feels reasonable. It is also very often wrong. Today, I am walking you through the 9 medications most closely linked to rapid memory loss in adults over 65. We are counting down from number 9 to number 1, from the ones that get quietly overlooked to the one I consider the single most destructive pattern I see in older patients. And I need you to watch closely when we reach number 3, because it is handed to millions of seniors every year for something that sounds completely harmless, and it may be physically shrinking the memory centers of your brain right now without producing a single warning sign you would recognize. Before we begin, drop your age in the comments below and tell me which medications you take every day. I read every single one. The age and experience of this audience shapes everything I cover next. Now let us start at number 9. And please do not let the low position fool you. This one is sitting in almost every medicine cabinet in America. Number 9 is diphenhydramine. You know it by its familiar drugstore identity, the little pink tablet people reach for when they cannot sleep, when allergies flare, when a cold needs taken down a notch. It costs just a few dollars. It sits on the open shelf without a prescription. And most people assume that because no doctor's signature is required to buy it, it must be gentle on the body. Inside your brain, it is doing something very different from gentle. Diphenhydramine belongs to a family of drugs called anticholinergics. That word sounds complicated, but the idea behind it is simple. Picture your brain as a busy relay station, constantly sending messages from one neuron to the next using a chemical called acetylcholine. Think of acetylcholine as the electrical signal that runs along the wire. Every time you learn something new, every time you stay alert through the afternoon, acetylcholine is the messenger making that happen. Now here is the critical part for anyone over 65. The aging brain naturally produces less of it with every passing year. So your brain is already running on a reduced supply of this signal. A drug that blocks that signal does not land the same way on a 70-year-old brain as it does on a 30-year-old one. It lands far heavier because there is far less reserve to absorb the hit. The part of the brain that takes that hit most directly is the hippocampus, a small seahorse-shaped structure buried deep in your temporal lobe. Think of the hippocampus as your brain's filing clerk. Every new memory you form has to pass through it before it gets stored. Block acetylcholine in that area night after night, and the filing clerk starts dropping folders. In my own practice, I have watched patients take a nightly antihistamine for years faithfully, as though it were vitamins, and slowly lose their edge. The sharpness dulls. The recall slows. And not once did they connect the morning fog to the pink pill on the nightstand. A 2023 paper tracking older adults who used anticholinergic drugs regularly found a 54% higher risk of developing dementia compared with people who stayed off them. More than half, again, the normal risk from something most people treat like a harmless bedtime habit. Here is the practical move. Read the label on anything you take to help you sleep and anything marked PM, nighttime, or allergy relief. Those products are very often just diphenhydramine wearing a different name. If you use it for allergies, there are newer antihistamines. Loratadine is a widely available example that work peripherally without crossing into the brain the way this older compound does. They are far safer for long-term use. And remember, never stop a medication on your own. Bring this information to your doctor. But stop assuming that over-the-counter automatically means safe for your memory. Those are two very different things. That is number 9. Number 8 is one your stomach may love and your brain quietly pays for. Number 8 covers a class of drugs called proton pump inhibitors. These drugs shut down acid production in the stomach, and they get prescribed and sold over the counter for heartburn, acid reflux, and that burning discomfort after meals. People stay on them for years, sometimes decades, because the moment they stop, the symptoms roar back. So the drug feels essential, like the only thing holding the line. Here is the part almost nobody hears at the pharmacy counter. Your stomach needs acid to pull certain nutrients out of the food you eat, and chief among them is vitamin B12, which protects the insulation wrapped around your nerve fibers and keeps your brain chemistry balanced. Think of that insulation the way you would think of the rubber coating on an electrical wire. Strip it away gradually, and the signals start to misfire. Reduce acid production far enough, for long enough, and your B12 drops quietly. So do magnesium and calcium, 2 minerals your brain cells depend on to fire and communicate cleanly. Starve the neurons of those building blocks, and you get misfires, confusion, and memory slips that look and feel exactly like early Alzheimer's when the real underlying cause is a nutrient. Your medication has been blocking all along. A large study published in JAMA Neurology examined more than 73,000 people aged 75 and older. Regular users of this drug class had a 44% higher risk of dementia than people who did not take them. And there is a second mechanism that runs even deeper than nutrition. These drugs have also been shown in research to raise levels of amyloid beta in brain tissue. Amyloid beta is the sticky protein that accumulates in Alzheimer's disease. So the pathway to harm runs in 2 directions at once. If you take one of these daily, that is the conversation to have with your doctor at your next visit. Many people can transition to a gentler class called H2 blockers, famotidine being a widely available example, which reduce acid less aggressively and are far less likely to affect cognition. Chewing deglycyrrhizonated licorice, a natural compound derived from licorice root that coats and soothes the stomach lining, can ease symptoms for many people with no cost to the brain whatsoever. The guiding principle here is the lowest effective dose for the shortest necessary time, not a pill you take forever simply out of habit. Number 7 is prescribed for a problem most people would rather not discuss out loud. Let me tell you about someone I will call Donna, 7'4", from outside Columbus, Ohio. Donna came in after her daughter practically dragged her through the door. The daughter's concern was memory. Mom kept repeating questions, could not recall conversations from earlier the same day, and had gotten briefly lost driving a route she had taken for a decade. When I sat down with Donna and went through every single thing she put in her body, including the over-the-counter items she had not thought to mention, she was on a bladder control medication she had been taking every day for nearly 3 years. Within 4 months of carefully transitioning her, with her urologist's involvement, to a different class of bladder therapy that works through an entirely different biological pathway, Donna's daughter called my office to say, and I quote, "She finished a crossword puzzle this morning for the first time in 2 years." Number 7 is the bladder drugs, specifically the older class of medications prescribed for overactive bladder, the sudden, urgent, impossible to ignore need to get to a bathroom immediately. The relief these drugs provide is real. The embarrassment and anxiety they spare people is real. But the most widely used older compound in this category works by blocking the same acetylcholine messenger that diphenhydramine blocks. And this one slips across into brain tissue very easily, settling right in the regions where memories are formed and stored. In 2019, the British Medical Journal published a study of adults over 65 who took strong anticholinergic drugs of this type for more than a year. Their risk of developing dementia was 49% higher, close to 1 in 2. And the detail that troubles me most is this. Almost none of them were warned. They were told a pill would calm the bladder. Nobody mentioned it might be dimming the mind at the same time. The fog gets blamed on age. The lost keys, the dropped conversation, the forgotten appointment, all of it chalked up to getting older. Very rarely does anyone trace it back to that daily prescription until real, measurable ground has already been lost. If you are on this type of medication and you have noticed your thinking slow down or your memory become less reliable, take that seriously and take it to your doctor, because you do not have to choose between your bladder and your brain. Newer drugs in this category work through a completely different mechanism and do not block acetylcholine at all. For most older adults, they provide the same bladder control with dramatically less risk to cognitive function. That option exists. Ask about it by name at your next visit. Number 6 may be the most surprising entry on this entire list because it is one of the most prescribed medications on earth. Number 6 involves a class of cholesterol-lowering drugs called statins. These are among the most widely prescribed medicines in the world, particularly after age 60, and they do an important job lowering LDL cholesterol, reducing the risk of heart attacks and strokes. Statins belong in many people's lives, and what follows is not a case against them. It is the half of the story that usually gets left out of the conversation. Cholesterol does far more than affect your cardiovascular system. Your brain is approximately 60% fat by dry weight, and it uses cholesterol as a raw material to build the myelin sheath, that insulating layer wrapped around every nerve fiber that allows electrical signals to travel fast and clean. Think of myelin as the fiber optic cable your brain depends on for high-speed communication. Lower cholesterol aggressively enough with a potent enough compound, and you can leave the brain short of a material it actually needs to maintain that wiring. A 2023 study in Frontiers in Aging Neuroscience found that adults over 70 who had been on statins for more than 3 years had a 26% higher rate of mild cognitive impairment, with higher doses associated with steeper declines. Some patients described frightening blanks, a familiar name gone, a conversation completed and immediately erased, a route driven for 20 years suddenly unfamiliar. These are not subtle effects when you are living inside them. The important distinction is that not every statin crosses into brain tissue equally. Some cross the blood-brain barrier easily, others do not. Pravastatin and rosuvastatin, for example, are generally considered the safer options for cognitive health because they are far less likely to penetrate brain tissue. If you have been on a statin for years and you are noticing increasing fog, forgetfulness, or confusion, that is a real and productive conversation to have with your doctor about either a lower dose or a switch to one of the brain-friendlier options. This is never a reason to quietly stop a drug that may be protecting your heart. Get the plan right with medical guidance, never on your own. Drop your age in the comments right now and tell me which of these first 6 you already take. I read every single one, and your answers help shape what this channel covers next. Now, here is a natural pause before we reach the most serious entries on this list. Everything you have heard so far, the over-the-counter sleep aids, the reflux drugs, the bladder medications, the cholesterol treatment. This is the kind of information that should have been in a printed handout at every one of those office visits. It was not, and I want to make sure you have more of it in one place. If you have found today valuable, the link in the description and the QR code on your screen right now will take you to a resource I put together specifically for adults navigating health after 70. It covers the medications worth questioning, how to use food as medicine, and a plain language guide to how your body changes after that decade. Everything I consider too important to leave out of a 1-2 minute appointment is in there. Check it through the description link or scan the QR on screen because what is coming in the final 3 entries of this list is the part I most need you to hear and remember. Number 5 is benzodiazepines, the anxiety and sleep medications sold under familiar names like lorazepam, diazepam, and alprazolam. These drugs work by enhancing GABA, the brain's own natural braking signal that quiets an overstimulated, racing nervous system. When someone first takes one, it can feel like rescue. The panic softens, the spinning thoughts stop, sleep finally arrives. Over time, the picture changes in a way that is rarely communicated clearly. A 2022 study in the British Medical Journal followed more than 8,000 seniors for 6 years and found that those who used this class of drug for longer than 3 months had a 51% higher risk of Alzheimer's disease. The longer-acting compounds were associated with the worst outcomes because they linger in the body and accumulate in fatty tissue, including, critically, the brain. What is happening is a slow chemical sedation of the brain's learning and encoding systems. The brain becomes less flexible, learns new things more slowly, and many patients describe a persistent flatness, a sense of moving through fog, of not quite feeling like themselves anymore. The cruelest feature of this class of drugs is the exit. Stop abruptly after weeks or months of use, and the anxiety and insomnia return with twice the original intensity, along with agitation that can be genuinely dangerous. That rebound makes the pill feel absolutely essential at exactly the moment it is doing the most harm. So the rule here is firm and non-negotiable. If you have been on this type of medication for more than a few weeks, do not stop suddenly. Work with your doctor to taper the dose down slowly over weeks or months. Gentler alternatives exist. Buspirone for anxiety, for instance, does not sedate or cloud cognition, and a structured form of behavioral therapy developed specifically for insomnia and anxiety can restore calm without any cognitive cost. Number 4 is a single pill prescribed for 3 entirely different conditions, and it carries one of the heaviest hidden burdens on this list. Number 4 is amitriptyline, an older antidepressant that remains in common use today for nerve pain, for sleep, and even for migraine prevention. That versatility is exactly why it spread so quietly it looks like a do-everything solution. Underneath that versatility sits one of the most potent anticholinergic drugs still in widespread use. It blocks acetylcholine so strongly and so consistently that with long-term use, the effect on memory stops being a rare side effect and becomes the predictable outcome. A landmark study published in JAMA Internal Medicine followed more than 3,400 adults aged 65 and older. Those with the highest cumulative anticholinergic drug exposure over 10 years had a 54% greater chance of developing dementia. And nearly none of them were ever informed that the pill could do that. They received it for pain or for sleep. Then they slowly noticed words going missing, memory thinning, concentration fraying, and they attributed it entirely to age. It does not require a high dose to cause this harm. A small nightly dose, maintained for years, can quietly erode mental clarity with no obvious alarm until the loss is already real and measurable. Let me tell you about someone I will call Gerald, 7'1", from a small city outside Nashville. Gerald came to me not for memory concerns, he came for a routine physical, but his wife had quietly written a note and slipped it to my nurse before the appointment. It said, "He is not himself. He forgets conversations we just had. He seems absent." Gerald had been on a low nightly dose of this type of medication for 4.5 years, prescribed originally for a pinched nerve. We worked carefully with his neurologist to transition him to a different pain management approach over about 5 months. At his follow-up, 6 months later, his wife sat beside him and told me the note she would write now would be very different. If you or someone you love is on this medication, that is a conversation worth initiating soon. For nerve pain, other options exist that carry far less anticholinergic weight. For sleep, low-dose melatonin or gentler compounds can substitute. For mood, newer antidepressants are considered significantly safer for the long-term health of the aging brain. Bring this to your doctor, not as a confrontation, but as a question you deserve an honest answer to. And now, number 3, the one I asked you to watch for. Number 3 is paroxetine. It belongs to the modern family of antidepressants used for depression and anxiety, the class most doctors would call safer and gentler than the older psychiatric drugs. On the surface, that reputation is largely deserved. But paroxetine is the one member of this family with significant anticholinergic activity. That single biological feature sets it apart from its chemical siblings in a way that rarely gets explained to the patient receiving the prescription. A large review published in Frontiers in Psychiatry in 2021 found that older adults taking paroxetine showed measurable drops in short-term memory, word recall, and sustained attention within the first 12 months of use. Seniors on this specific antidepressant were 30% more likely to show early signs of cognitive impairment than those taking other antidepressants in the same family. The hard irony in that statistic is significant. This drug is prescribed specifically to steady and protect the mind, and over time it can erode the very clarity it was meant to restore. The American Geriatric Society placed paroxetine on what is known as the Beers criteria, a formal, rigorously maintained list of medications considered inappropriate or high risk for adults over 65. It is on that list for exactly the reasons I have just described. If you take it, ask your doctor about transitioning to a different compound in the same therapeutic family that does not carry the same cognitive risk. That conversation is worth having, and your doctor should welcome it. Number 2 is so quietly prescribed that many people taking it have no idea what category of drug they are actually on. Number 2 is the atypical antipsychotics. These drugs were built and approved for serious psychiatric conditions, schizophrenia, bipolar disorder. Today, that are increasingly prescribed off-label to older adults for sleep difficulties, mild agitation, and the behavioral restlessness that can accompany dementia. Powerful medications designed for severe psychiatric illness now being used in homes and residential facilities on seniors who are confused, restless, or difficult for a busy caregiver to manage. The cost of that expanded use is steep. A 2022 study in Lancet, Healthy Longevity, followed more than 25,000 older adults and found that those given antipsychotics for behavioral symptoms were 71% more likely to experience worsening cognitive decline within a single year, even among those with no documented cognitive impairment before they started. These same drugs also elevate the risk of stroke, sudden cardiac events, and heavy sedation that contributes to falls and hospitalizations. They work by suppressing dopamine, a chemical tied not only to mood, but to focus, planning, motivation, and memory. Suppress dopamine far enough, and the brain becomes slow, flat, and unresponsive. Families watch someone they love seem to disappear while sitting right in front of them, and they grieve a decline they believe is the natural course of aging. Very often it is the medication. If you or a loved one is on one of these, the first move is to ask the prescribing physician a direct question. Why was this started, and is it still necessary? Most behavioral symptoms in older adults can be eased without medication through consistent daily routines, reduced environmental noise, and overstimulation, treatment of underlying pain, which is very frequently overlooked as a cause of agitation in seniors, and attention to sleep and light exposure. When medication is genuinely necessary, the lowest possible dose for the shortest possible time is the governing principle. Far too often, no one tells the family what these drugs do to the brain over time. Let me tell you about someone I will call Margaret, 80, in a memory care facility in Phoenix. Her son had been told her rapid decline over 7 months was simply the natural progression of her early stage diagnosis. When I reviewed her chart as part of a consulting arrangement, she had been placed on an antipsychotic after one episode of nighttime agitation and had never been reassessed. We worked with the facility's medical director to taper and discontinue it slowly over 6 weeks, and introduced a structured evening activity routine instead. 3 months later, her son described having real conversations with his mother again for the first time in nearly a year. And now we arrive at number 1, and it is not a single drug at all. Number 1 is anticholinergic polypharmacy, the combined stacking burden of multiple medications, all blocking the same critical brain chemical at the same time, with nobody in the room adding up the total. You may have been waiting for one final villain, a single worst pill. The real worst-case scenario is subtler and far more common. The slow compounding effect of taking several medications with anticholinergic properties simultaneously, with none of the individual prescribers aware of what the others have prescribed. Polypharmacy simply means many medications at once. Anticholinergic burden is the combined weight of all of them landing on the same memory system together. Picture a very ordinary situation. An older adult takes a nighttime antihistamine for sleep, a bladder control medication every morning, and a low dose of an older antidepressant for nerve pain at night. Each one, evaluated alone, might cause only a modest, barely perceptible dip in cognitive performance. Taken together, they compound. The total blockade on acetylcholine climbs fast and stays high. In 2022, a study in Age and Aging tracked more than 280,000 older adults and found that those with the highest combined anticholinergic burden had a 120% higher risk of dementia within 10 years, more than double. And the great majority of them had never been told they were on anticholinergic drugs at all. When you block acetylcholine from multiple directions simultaneously over months and years, the brain does not simply run quietly at a lower level. Neurons begin to wither from sustained underuse. Connections shrink. The brain settles into a chronically underpowered state that looks nearly identical to Alzheimer's disease on cognitive testing. Families watch. Doctors document. And the cause, a correctable, iatrogenic, medication-induced cause, goes unaddressed. Here is the hopeful part, and it is the reason I made this video. Drug-induced cognitive decline is frequently reversible when it is identified early. Remove the burden, and many patients recover meaningful clarity, energy, and memory within weeks to months. The brain at any age is more resilient than we give it credit for, but only if we take away what is hurting it. The recovery does not require a miracle. It requires a careful, systematic medication review. Sit down with your doctor or your pharmacist and ask them to go through every prescription medication, every over-the-counter product, and every supplement you take, and to assess the combined anticholinergic load. There are validated scoring tools designed to do exactly that in a single appointment. Once the contributing drugs are identified, tapering what is unnecessary, switching to safer alternatives, and monitoring the brain's response gives many people their lives back. This is the most preventable threat to the aging mind I know of. That is why it is number one. Now, I want to hear directly from you. Of these 9, which ones are currently in your medicine cabinet? Have you noticed fog, forgetfulness, or a sense of not quite being sharp creeping in after starting something new? Tell me below. And please tell me you will bring this video or a printed copy of this list to your doctor this week and ask for a medication review. Your comment might be the thing that gives the next person who reads it the courage to do the same. This information is educational and meant to open a conversation with your own physician, not to replace one. Never stop or change a medication on your own. Bring this to your doctor. That step, taken thoughtfully, is how real change happens. Your medicine cabinet holds one set of clues about your brain health. Your own hands hold another set that almost no one knows how to read. Your fingernails can signal trouble brewing in your kidneys, your blood, and your nervous system years before any other symptom appears, and most people walk right past those signs every single morning. That is the next video. I will show you exactly what to look for and what each sign means. I will see you there.